Thank you everyone for joining us today in our new chapter of OBTO. OBTO stands for Oncology Beyond the Obvious. Normally, we hold this webinar every second Tuesday of the month at 7 to 8:30 p.m. We select one particular paper, and this paper is dissected in detail over 90 minutes. The first 30 minutes is interview with one of the expert in the field. The second 45 minutes is the panel discussion, again moderated and paneled by again experts in that field. And finally, there is an expert comment of 10 minutes which summarizes that what all have we discussed in last 1.5 hours. Is it really practice changing? Shall we be adopting that in our day-to-day practice or not? And if yes, why? And if no, why? So this is our format of OBTO. It is more than 1.5 years when we started this. Dr. Purvish Parikh sir and myself, we are the program directors for this OBTO. We are very happy and lucky that we have received a good welcome to this OBTO program. In fact, recently we came to know that there are 3 large hospitals who have made almost mandatory for their DM and DNB students to attend this OBTO program. We have been approached by various other platforms also to conduct OBTO. One of the things which we have maintained is it's only science discussion for 90 minutes, what we have. And with that in background, I would, today's topic, it is, surgical oncology topic, but since it is OBTO is oncology and we can take anything. So today we are discussing one particular paper where can we improve the intraoperative resection rate for ovarian cancer. And as I always say, Tongaonkar sir in every forum, that as of today, ovarian cancer, if we use the word cure, we need to have an excellent surgery of our patients. So take this forward. I would like to invite Dr. Purvish Parikh sir. He will be interviewing today Dr. Somashekhar and he will introduce him. But first, let me introduce Parikh sir. I always say this sentence that if anyone does not know Dr. Purvish Parikh, probably he or she is not an oncologist or not a doctor in India. Parikh sir has been backbone to many students like me. I am his ardent fan and student. In fact, somebody, when they call me Parikh sir ka pankha aaya, that also I enjoy when I hear that. But talking about OBTO, he has been like actually a backbone of OBTO. We dissect out papers, we select papers, we select people whom we will invite. And everywhere Parikh sir's support is there. And as a result, today this program is where it is. Sir is recently Professor and Head of Clinical Hematology, MGMCNH, Jaipur. Previously, we all know that he was Professor and Head of Medical Oncology in Tata Memorial Hospital. Sir has a lot of articles to his credit, and he dissects the paper much more in detail than what we do in OBTO. And with that, I invite Dr. Purvish Parikh sir to take this program forward. Over to you, Parikh sir.
Thank you very much, Amish. I will start by sharing my screen. I'm sure that you can see my screen now. So it's really nice that we have taken this surgical topic for today's discussion. And I must thank Dr. Ajay Bafna for making the suggestion to use this particular publication. So first, let me start by introducing Dr. S.P. Somashekhar. Again, like Amish said, Dr. Somashekhar needs no introduction to most of us. But it is still my duty and my pleasure to do so. So please allow me a few minutes to do that. He is chairman of the Aster DM Healthcare GCC for GCC and India. He is global director Aster International Institution of Oncology. and is the head of the Department of Surgical and Gynec-Oncology. So clearly, this publication that we are going to discuss is in his domain. He is also the Berkeley Barry Cooper Professorship at King's Health Partners UK. And I think that is a big feather in his cap because UK is recognizing him as a professor. And we all know his passion is HIPEC and PIPEC, so he's the director of those programs. He's also director of 3 fellowship programs, including robotics. While he was undergoing the training in Gujarat, he was recipient of the gold medal as well as the D.D. Patel Gold Medal for excellence in oncosurgery. All of us in the morning, when we open our WhatsApp, we see what he has read in the previous day and the synopsis of important publications. So it is not a surprise that he is also an author of several textbooks of oncology and more than 300 publications to his credit. He is editor-in-chief of Springer's Indian Journal of Gynec Oncology. He is also editor of Annals of Breast Disease Journals. But the main reason why he is being interviewed today is what is below. We are talking about ovarian cancer. We are talking about peritoneal surgery. And he is the EC Council member for Peritoneal Surface Oncology Group International. And is already doing at least 2 trials and is going to do a 3rd one in this field. He is council member of International Society of Study of Peritoneum and Pleura. He is council member of the Association of Gynecology Oncologists of India and is honorary secretary of the Indian Society of Peritoneal Surface Malignancy. So you will all agree with me that if there is one expert whom we needed to interview on this topic, it is Dr. Somashekhar. With this, I will first start by showing you the highlights of the publication that we are going to be discussing today. And this is mainly for the postgraduates who may not have read the article before they listen. And unless they know the highlights, they will not be able to understand the depth of the discussion that we are doing. So this is a phase 3 study of Pafolacianine injection for intraoperative imaging of patients with ovarian cancer who are folate receptor positive. This is intraoperative molecular imaging. Pafolacianine was given for real-time detection of folate receptor positive ovarian cancer. And this is because it can identify lesions which are not visible under white light or by palpation. So the primary hypothesis is that it will improve surgical resection of such tumors. And we all know that R0 resection is so vital in ovarian cancer. This is a phase 3 open label study with 11 centers. Patients were included if they were known or suspected ovarian cancer when scheduled for cytoreductive surgery. Pafolacianine was given in the dose of 0.025 milligram per kilogram IV, and it was given at least 1 hour before the surgery started. And intraoperative imaging was near infrared imaging to detect the lesions. Now, this is the workflow. So, all patients after getting the injection were evaluated with normal conditions. So, white light and palpation. And after that, they were randomized to only white light and palpation, which was the control.
Sir, we can't hear you.
Yes, sir.
By any chance, have you muted yourself, sir? We can't hear you, sir.
Sir, we cannot hear you, sir.
Hear me now?
Yes, sir. Now we can hear
Yes,
you, sir.
sir.
But the
Okay,
slides
perfect.
are not visible.
I will restart this. So
Yes, sir.
this is
Now
how
we-
the folate receptors are seen on histopathological examination. Okay, on the first column is positive control, the second column is negative control. The third and fourth column are score 1 and score 2. And you can clearly see that score 3 is very, very obvious, right? And this is what is seen when the person is operating. On the left side is with white light, and on the right side is after the near infrared imaging fluorescence is initiated. And I will leave to Dr. Somashekhar to explain to you how this is really crucial. Now, 140 patients were included, 134 were assigned to the study arms, and out of them, there were some which did not have FR positive malignant cells and they were excluded. So finally, the analysis was 109 patients. And out of them, 3 patients did not get the correct Pafolacianine dose. So they were analyzed. So per protocol analysis was 106 patients. So out of these 109 patients, 36 had at least one additional evaluable FR positive ovarian lesion, which was confirmed by central pathology detection. And this was on tissue which was not planned for resection based on white light or palpation. So this exceeded the pre-specified threshold. Oh my God. Am I back? Sorry, yeah.
No, sir, we can hear you, sir. No problem. No interruption. It's smooth, sir.
Okay.
Go ahead.
So exceeded the pre-specified threshold of 10% and the p-value was 0.001. So 69 patients with at least one lesion removed, which was detected under normal circumstances, that is white light and palpation. And 47 were detected and removed only because of the study arm. So I think this is a big number. So the study conclusion was that this intraoperative fluorescence imaging improves detection of malignant lesions during surgery. And the primary endpoint was met as per and exceeded the pre-specified threshold. So this is I will stop sharing the slide now and we will go to asking the questions. So as far as the questions are concerned, I'll start with one rapid fire yes, no sort of or single sentence questions that sets the background. And then we will go on to the protocol itself. So, Dr. Somashekhar, does ovarian cancer still have the highest mortality rate among all gynecological cancers in India?
Which is absolutely true, sir, because it started off with 90% mortality at 5 years, and in spite of everything, it is as bad as 70 to 60% mortality, and it's only very close to a pancreatic cancer. So, unfortunately, among the gynae-onco in India, ovarian cancer has the worst prognosis by virtue of 76% coming in stage 3C, and in them, the 5-year survival is very poor.
So, as far as the 10-year survival is concerned, it was 18% in 1970s, increased to 35% in 2010. Now we are in 2023. What is the 10-year survival today for all ovarian cancers?
Yeah. So for all the ovarian cancer, if you look at all the group, it is still not more than 40 to 45% all the group. But that specific group of stage 3C, only marginal improvement has happened. Most of them are shifted to stage 1, stage 2.
Right. So this year, there was a meta-analysis published that says the overall survival in published literature has not changed in the last 10 years. Is that also the experience in India?
No, sir. And I would partly not fully agree on that. Last year, the GOG group and the ESGO group brought out the full algorithm of the survival benefit over last 30 years, what has happened. In 1989, what was the overall survival across the globe as a 24 months, 5 years survival? 24 months was the total survival median. Has jumped to 49 months somewhere around 1992. Then it went to 65 months, and now it stands at around 80 months. So definitely overall survival has changed. And in India, since we don't have a across the globe registry which published, the only thing which I can extrapolate is the Indian Society of Peritoneal Surface Malignancy. When we looked at the last 7-year time frame, because this is only 7-year registry, initially it started off with 32 months as a median OS. He's now gone up to 60 months. So definitely in India, it has moved in a snail place, but there is definitely a positive trend.
Okay. So the main problem for ovarian cancer patients in India is when they are operated in the community by a gynecologist or a surgeon, and they either do unnecessary open and shut cases or they do suboptimal surgery. Has that changed? Or what percentage of patients, when they come to you, they get treatment outside and then they come to you? How many of them have received suboptimal treatment?
Unfortunately, even everybody would agree along with me, Dr. Amita, not much has changed in last 7 to 10 years, even though so much of education has happened. Even today in ovarian cancer, somebody who is practicing in a center like a metro or a tertiary, 40% of the patients are totally inadequately staged, so which is extremely bad. But I have not changed any great change in last 5 to 7 years in this number, in spite of the educative activities taken by various forum in India, which is very sad.
Right. Now let's come to the publication itself. And the first thing is that there were some patients who were not eligible for entry into the study. And this included patients who were laparoscopically operated or where robotic surgery was done. Do you think that is a significant limitation of how we interpret this data?
No, sir. Actually, since this is the first randomized trial which looked at it, they eliminated 4 categories in this. One is a patient who was only planned for laparoscopic surgery, or a robotic, which is minimal access, or a patient who had a miliary disease where obviously they're not going to end up with surgery. Then whether you have a microscopic, macroscopic, residual didn't matter. One of the reasons the authors did this is they wanted every nook and corner of the abdomen to be inspected, and they believed minimal access would miss in all the hidden area, and we may just look at the central abdomen, small bowel, and the actual proof and the strength of statistics will not come. So before it is applied to minimal access, because it is not easy to go above the diaphragm or into the retroperitoneum, into the paratic area or the omental bursa, they wanted it to be applied in open to see the proof of concept and then apply in laparoscopy. It is not that it cannot be done in lab robot. In an initial phase, first in open surgery where everything is visible, they wanted
so
to do
you
it.
are saying that this is actually the strength, not the limitation of the study, that they have
Yes,
limited.
absolutely.
Yeah.
Yeah.
Right.
Because
Now
there is
there
a
were
counter development happened in the similar field of fluorescence guided surgery in colorectal. There are 2 other agents like this, and they have allowed laparoscopic and robotic, and they are equivalent to the open arm. So it has not yet come in.
we'll limit to
Yeah.
this publication. Now there were 10 sites in United States and 1 in the Netherlands. So why did they need to include another country? Was there any specific or regulatory issue? What was that?
They actually wanted to involve Spain and Italy also in this trial. They tried actively to make it multicentric. But following things has to be done. So the Pafolacianine, which is a Cytolux, is a US FDA approved drug and it is easily available. And the main sponsors were from US. And the main idea behind this was the team from the UPenn. So they tried to recruit both the Amsterdam Netherlands group and Italian group and Spanish, but they couldn't do it in the given time. I agree they would wanted to do it, so only one center they could recruit outside US.
Right. As far as the study procedure is concerned, I'm little concerned about the way that it was randomized. The ratio of randomization was 20:1. And I've never seen any study published where it could be 1:1 or 2:1 or 4:1, but 20:1. What are your comments on?
Yeah, sir, it's very important to understand this is not a medicine drug trial to look at it. Now, why 20:1? Even within that one group and 20, every patient has 2 randomization, which means there is a 2 arm. One is on a white light they have done, then they look back with the fluorescence. So in effect, this actually doesn't need a randomization because every patient initially is blinded. They're looking at white light, whole survey is gone, then they would actually put the fluorescence. But why this randomization is required? If we read the in between the line, the authors were worried that if every patient is going to look in white field and then fluorescence, the surgeon may not put enough effort to visualize. They would think, anyway, I'm going to shine through the fluorescence, I may pick up, and that may actually unnecessarily give an undue arm and power to this. Second issue, if you shine through many areas and you remove extra disease, they were not sure will that harm the patient. So they wanted one control arm to put into the surgeon that there is a randomization, don't believe that there is a fluorescence coming. I may stop in your case at visual inspection and you may harm the patient if you don't do. So by this just small randomization 21 that ensured this quality, but every case otherwise has been into 2 arm either way, except 6 patients. All the patient had both.
Right.
So it is not a limitation. It's fine. It's totally fine.
So such dyes used for assisting surgery is not new. It has been there in many conditions. And like you mentioned, for colorectal cancer, even for lung cancer and head and neck cancer. But indocyanine green and methylene blue were used in the past. Why this need to change from a cheap available drug to a more expensive drug for such a surgical procedure?
Absolutely, you're absolutely right. I was part of a trial in ovarian cancer with ICG. Now the problem with ICG is it has to be given 6 hours before. Typically, we start a surgery at morning 7:30, waking up the patient at 2. I remember in 10 of my patients, they literally cursed me because we had to give it 6 hours before, number one. Number two, ICG has a half-life of about 3.4 minutes, which means it gets washed away very quick. And if you delay in shifting the patient or you open the abdomen later, as you proceed in the surgery, you delay 1 hour, it is washed off. And it is not specific to the cancer cell, it also takes up in the liver. So we had a dye which has to be given 5 to 6 hours early, which is not tumor specific, and it is washed off very fast. So that's why it is not specific. And that's why we required a dye like this, a drug, which is specific, can be given just 1 hour before. And the beauty is it stays throughout the surgery. You may give in the morning, you may even operate in the night, it stays in the tumor. So it's a good drug.
Right. But it requires folate receptor positivity to use this. So why did the study design not say that we will first identify whether the patient's tumor is folate positive and then only include the patient in the study?
Absolutely. 2 reasons. One is ovarian cancer, 91 to 99% actually, it shows, which means there is 7 to 8% only. Second, if you look at this particular paper and study, 45% of the patient are upfront. We know very well worldwide in ovarian cancer, if you choose a surgery as a modality, it is not mandatory to have neither cytological or biopsy. But if you use for interval cytoreduction, you need a proof. So now if they had made it a mandatory criteria that, you need to have a biopsy, because biopsy is required to prove that this is a folate receptor, then unwanted laparoscopy, 1 biopsy, 1 anesthesia, then wait it to central lab, bring back, too much of cost, too much of problem. So that's why they couldn't do it. But in next phase, probably a logical conclusion of this would be to do that.
In the secondary objective of the study, they were looking at false positive and false negative rates. And this was divided into patient level false positive negative and then lesion level false positive negative. Your comments on that?
Yeah, absolutely. Actually, this is perfect because this answers the first question. Since we are not confirmed this every patient that is recruited are folate positive. So that's why there are 2 false positive. If you take a whole tumor group as it is, there are about 9 to 10% of the patient who are folate negative. So there will be more false positive. But when you look at the whole patient group into 2, it would not be. So unless you prove and take eligible patient who are folate positive, it is nice to distinguish between both. That's why the false positive, which was more than 34%, almost 1/3, dropped down to about 20-23. Probably if it is refined better, we can bring this false positive further less, close to 10%.
If you look at all the patients who were analyzed, that 109 patients, it included not only ovarian cancer, but also those with primary peritoneal cancer and also unconfirmed high clinical suspicions of ovarian cancer. Do you think that the second and third should not have been included and they should have restricted only to ovarian cancer?
Yeah, ideally that is right. But the way is, as I told you, 45% of the patients are primary cytoreduction, which means they just have ascites, diffuse omental nodules, and some bulky ovary. And there was no way they would have known that is it a primary peritoneal carcinomatosis, undifferentiated sarcomas. And they ended up with this group unless all the trial was in interval. But having said that, those group constitute less than 5 to 7%. So it didn't adulterate the overall picture, but it would have been nice to exclude them.
All right, right. Now coming to the adverse events, it happened in about 18%, that is 28 out of 150 subjects. There was an interruption of the infusion because of the adverse events. Now, medical oncologists are all used to adverse events like nausea and vomiting. But if the patient is on the table on your operation theater and he starts vomiting, it's a big problem, I'm imagining. So how do you handle that?
Absolutely. I fully agree with you. Imagine a patient is ready to go for a marathon surgery 1 hour later, and you put an experimental drug into the patient in the ward, which they're giving in 25% dextrose, 1 hour infusion. And if you look, some of them went up to 55 minutes. And then patients start puking and having nausea, pain, abdomen, even before he is wheeled in. The psyche of the patient, the family, and the doctor is going to be very, very tough. I agree with you. This is a major concern. Sometimes patient may drop out. They say, I will not. But luckily, when you look at this analysis in the paper, I specifically looked at this. Serious adverse event and mild, moderate, severe reaction is different. Even though adverse effect was very high, most of them fell into mild and moderate. Severe was very minimal. Now, there are only 2 patients who totally got aborted outside the protocol because of the reaction, which means they started off with 160, 170 plus, then they came down to 107, only 2 patients. But however, there is one more line, 6 patients, 50% of the drug has to be given because of side effect. But the authors have finally concluded that there were no severe adverse effect in any of the patient. It affected only 2 patients. By far, it's okay, but that's definitely a concern, especially when you have to give pre-op before patient is anesthetized.
All right. So 22 out of 28 patients were able to resume the infusion. So 6 patients, the infusion could not be completed. In 3 patients, they had received the total dose was less than 50% of the intended dose. And actually 2 patients died, one of septic shock and one of worsening renal function. But they said that this is unrelated to the study. They were already existing comorbidities, and that was the reason. So it's a fairly safe drug, and possible, technically it is possible to use that. Now, there are the authors themselves have shared 2 limitations of the study, and I think both of them are very important. One is that there is no multi-year follow-up data. So we don't really know whether all this heroism is actually going to improve the overall survival or the cure rates of the patient. And the second is that if there is a false positive, then because of this intraoperative imaging, we might actually do unnecessary surgery. So what are your comments on that?
I entirely agree with you. The reason is chasing small disease and translating to OS itself is not proved. Like in the field of ovarian cancer, total peritonectomy when it looks normal versus selective peritonectomy itself is a big debate for benefit of either one of them. But when we look at this particular disease, it is found as per the GOG trial that any nodule which it is less than 10 millimeter, probably you remove or not remove with a good treatment, paclitaxel, Taxol, and then bevacizumab or PARP, probably it should not alter OS. But the beauty in this particular study is I carefully looked at the paper. They identified the lesion which otherwise by visual inspection on a white light and palpation up to 1.1 centimeter has missed. If there is a nodule more than 1 centimeter, definitely if this is picking up. So that is the beauty. The lowest particulate it was showing was 3 mm, and up to 1.2 centimeter, that is a 12 millimeter, it has missed and it picked up. So I couldn't get the data, how many were above 10 millimeter, how many were below. So if there is a substantial amount at 10 and 11, yes, then it would matter in OS. If majority are below 1, as of now, it is not proved, and time only will tell with adding bevacizumab, PARP inhibitor, and good chemo, really what is the incremental benefit that would come over and above. Second issue, there were almost, there are 2 points which they have written. 29% of the time, they have found a lesion positive, which otherwise white light would have not done. Which means, remember, 6 to 7 areas you went and looked. In the annexure and the supplementary material, they have mentioned which are the places they did extra procedures. Did a para-aortic lymph node, celiac node, right and left para-caval, and then a hilum of spleen. These are not easy areas to visit, especially if a surgeon is in learning curve. That itself may end up with more morbidity and mortality. So it's a very important issue. But however, authors have themselves answered that that particular group where they did extra procedure and they compared with the other randomized, it didn't show a significant change in the morbidity. But remember, it is 20:1 randomization for complication, only 6 cases versus 100. It is little too underpowered in that aspect, which needs to be really tested in real world scenario.
Right. So again, we had alluded to earlier, when the imaging is done after fluorescence, what exactly do you see? What is the change in color? Is it blue color? Is it red color? Is it green color? Because I've never seen, so I'm asking.
Yeah, so it's really beautiful when you throw white light, especially in this particular paper. More than 55% of the patients are after chemo. Now, when we as a surgeon go in and do laparotomy for ovarian cancer interval cytoreduction, except the 2 ovary and small omental granularity, most of it look like a plaque and fibrosis. Now imagine I see a plaque and a fibrosis on a small bowel. I don't know there is a trap cancer cell, not there. Should I resect? Not resect. And such 100 decision at different places on spleen, stomach I have to take. The moment we shine through this special, in this particular study and paper, predominantly they've used Olympus, the Olympus firefly mechanism, which I have, and I use the same one also. Suddenly what is white, it will show a trapped fluorescence, greenish, orange and red hue. A scar is bland white or it is showing. It really shows a very beautifully trapped cell. Suppose you open the para-aortic, there are about 50 nodes. You don't know which to remove. In fact, the photo which the author has put here is that of a right common iliac node. They open the space in the photo, everything looks normal. The moment you look through the fluorescence, only that one node which is positive, which is actually more than 1 centimeter is seen. It's like a Superman, a blind man is suddenly get a vision while operating. It's really good.
Wonderful. Thank you very much for your expert comments on the publication. Now I'm coming to a rapid fire question. Again, very, very brief answers. Do you think that this phase 3 study provides sufficient evidence to use this in India?
I will put it this way. Everybody is thinking I will use this to do more advanced cytoreduction to remove more and more disease. I'm cautious. I would use it the other way around. Now imagine I decide it's an easy surgery. This patient will have overall survival. The moment I use fluorescence, I know that there is more disease than it is available. Then I may decide not to harm this patient. Because suppose the PCA is very high and it is in a hidden area. Imagine all the small bowel looks normal. I put a fluorescence. Most of the small bowel is fluorescence. I know no matter what cytoreduction I will do, I will not. So as of today in India, it may not change to add more cytoreduction. However, it will definitely help us to select the patient who may not be eligible for high aggressive heroic surgery with or without HIPEC. So maybe it's better to look at the other way around first and then come back to advanced cytoreduction.
So once it becomes available, I think very few centers in India would actually be able to use it and take advantage. How many do you think would we actually be able to use?
Probably 7 to 10 center, because currently the operating system is 1.2 crore. Don't just look at the dye. Dye varies between $1,800 to $2,500. But the fluorescence machines which are there are usually 1.2 crore. But luckily, most of the hospitals have it for some other reason. You have to beg, borrow, steal and do it. But it's not easy to be practiced in most of the center.
Right. Also, just as in HIPEC, I believe that there will be a very steep learning curve. So before I trust my patient to a surgeon, how many such procedures should he or she have done?
Yeah, luckily the learning curve in this is less. The answer is I am part of 2 randomized trial in the similar fluorescence in PSM from 2 European. Between me and my team, about 5 to 7 was the learning curve. So Luckily, it is not very high like the other step. Even advanced surgery for ovary, typically it is told 30 to 60, HIPEC is 90 to 100. Luckily, here it is in single digit, so easily reproducible. Even within the paper, they have commented about this learning curve. They found that how to bring down the false positive rate was 4 to 6 training of surgeon, 4 to 6 cases suddenly improved. So learning curve is in single digit.
All right, right. Now, looking at the future and translating this into systemic therapy, we already have some molecules, monoclonal antibodies like mirvetuximab, that are actually being used for treatment of patients, especially those who are refractory to platinum-based chemotherapy. What do you think is the future of such targeted therapy in saving lives and improving the cure rate in ovarian cancer?
I am extremely excited. In fact, using this fluorescence in not to do aggressive surgery, but to triage the patient who should not undergo aggressive surgery and who are those patients who could actually go on this Mirosol trial. If you look back, imagine if you do a laparoscopic or robotic, you give IV Cytolux, and then you can make out there is a diffuse folate receptor positivity and all over distribution. And then if you can use, drug conjugate anti-folate receptor. If you look back the trial, what I'm excited is 14% complete response. Imagine in recurrent case, interval cytoreduction, where less of surgery or any of the medicine is available, it's very exciting. So because 14% complete response and overall survival jumping, I would say that this dye now can be used to see, especially in recurrent setting of ovary, which are the patients who should not undergo secondary cytoreduction, instead should go to this drug. Probably that will give the same result as a advanced cytoreduction with less morbidity mortality.
Excellent. So thank you, Dr. Somashekhar. We come to the end of the interview, but you will continue as a panelist, and I will hand over back to Dr. Amish Vora to continue the proceedings for the next part.
Thank you, sir.
Thank you, Parikh sir, and thank you, Dr. Somashekhar. I think for a non-onco surgeon, everything was a learning today. Of course, not that I'm going to ever go back in the OT and trying to do it myself, but at least, we come to know about how difficult it is for surgeons to achieve R0 resection. When we keep hearing 40%, 50%, we say, kya yaar? Matlab, why so less R0 resection? But then we realize that, so many things are involved. But it was really, really very interesting discussion between two of you. And thank you, Dr. Somashekhar, again for taking out your time. With that, we move forward, and it is now time for panel discussion. And our moderator today is Dr. Amita Maheshwari. Dr. Amita Maheshwari is surgical oncologist, gynae oncologist, and professor in Tata Memorial Hospital. She actually, in my private practice, whenever there is any gynec oncology issues, she's my go-to person. I'll start typing messages to her, and she will many times answer about medical oncology aspects also. Dr. Amita is very, very thorough surgeon. Whatever time we were colleagues, I have seen that her surgical finesse is very, very good. That is what I have learned from her colleagues and the results of her surgical cases. In fact, during panel discussion at various forums also, she goes into the details of the paper or the topic which we are discussing. And I think she's an apt person to moderate this particular paper, which I find it quite difficult. But I'm sure she would have understood it well, and she would take this forward. Dr. Amita Maheshwari, thank you so much for joining on this forum. And may I request Kavina Creations to introduce our panelists, please?
Yes, sir. So we would like to invite our panelists, Dr. Hemant Tongaonkar, Dr. Rama Joshi, Dr. Satinder Kaur, Dr. S.P. Somashekhar, Dr. Ajay Bafna, and Dr. Aditi Bhatt. Over to you, ma'am.
Very good evening. And thank you, Dr. Vora, for kind words. You have really put me under tremendous pressure. Thank you, Dr. Parikh, for having me. Am I audible?
Yes. Yeah, fully loud.
Yes, yes.
Okay, so let me start this discussion on a lighter note. that finally surgeons also got a tongue twister targeted agent. Of course, in our case, it is to remove more cancerous tissue during surgery. So, we have this molecule, what we were discussing. Amish asked how to pronounce it. I don't know whether to call it Pafolacianine or cyanine, but anyway. So, in fact, this small study of 150 patients, which looked at just safety and efficacy to pick up additional lesions, actually led to, interestingly, FDA approval. In fact, before this publication came in public domain. So, in fact, in November 2021, the molecule was approved for ovarian cancer identification during surgery. So, we heard that very exciting results and very important outcomes, but, we also need to see the results of this study critically and also see the real-time utility of this molecule, what Dr. Parikh already asked, in our clinical practice. And to deliberate upon these points, we have really an elite panel of experts. And before I start, let's just put things in perspective. We know that ovarian cancer is the third most common cancer in Indian women, and globally, majority women presents with advanced stage disease. And what we also know from almost every publication is that a complete removal of all macroscopic disease, either at primary surgery or at interval debulking surgery, whichever settings, is the single most important prognostic factor for survival in patients with advanced ovarian cancer. So here we have a molecule which claims to pick up things beyond what we can see or we can palpate during surgery. In fact, what this study showed that nearly 33% patients, 1 in 3, we could identify an additional lesion that was not detected by white light or by palpation, and this was not in the original surgical plan. And this figure was even higher for interval debulking setting. So my question is, and to all surgical colleagues, are you really excited with these results? And do you think we should include this in our clinical practice from tomorrow? So may I start with Dr. Tongaonkar or Dr. Joshi?
Yes.
So one quick comment. What do you think about the results of this trial and their clinical relevance?
I think the results are very encouraging, and all of us who treat, who operate on ovarian cancer, we know the limitations of surgery. And if we could get an agent which would highlight the areas which are going to leave behind, and probably they may have disease, I think it's definitely a step forward. There are concerns before we can adopt it into routine clinical practice. And we need to have more experience, more trials before we can do that. The main concern is the false positivity.
Looking at
secondly, the actual endpoints of survival are not addressed in this. So we make, identify more and more sites, but does that really actually translate into survival? Same thing happens with lymph nodes.
Right. Yeah? Absolutely. Yeah. Dr. Joshi, one quick remark on your take on the study results.
Actually, when I look at this study, there are a lot of limitations which I could actually point out. How did they select the patients? And giving this particular, actually the dye to the patient in order to picking up. They have, if you look at Amita, they have excluded the patients, 7 patients, right in the beginning of extensive, you can say, the disease. And what is this extensive means, we really do not know. There is no way by which they have defined the type of the cases to be included in the study. What was the PCI? What was the range of the PCI? What was the minimum, you can say, what was the mean PCI? And also they have included the patients from the various stages, especially the early disease. That is stage 1 as well as stage 2. That includes almost 15% of the patients included for this study. So basically, how did they even actually stage these patients? Did they use this particular dye, or you can say the fluorescent lesions, and they excised all those fluorescent, you can say, marked peritoneal, maybe for the peritoneal biopsies, or how did they really stage these patients and come to the status of stage 1 or stage 2 disease, and using this particular Pafolacianine, right? This dye. So there are basic things which I feel that if I'm palpating actually the disease, which is very bulky, I think there are multiple disease, actually the sites which we will be able to palpate. And we may not be able to see. That means we should be able to find out the areas where the disease is comparatively in less volume. And the disease is less, actually, you can say, distinguished on the clinical evaluation. So I really fail to understand what was how did they do their preliminary evaluation.
Yeah, I think what I understood
stage
is
3C disease. I think it's a very important point. So for us considering this particular, actually the study that is.
Amita, can I just add a line?
Yeah.
Can I just add a line to
Yeah,
Rama?
sure.
Rama, if you open the supplementary material, it is all mentioned there, quadrant wise. Where is the disease earmark? What is stage 3A, 3C, 3B, and what is a miliary disease on the small bowel, and which quadrant had it is very nicely written. It's not in the main article, but there is an access to the supplementary, which is very well defined. The whole purpose of miliary disease, they told, is if there is a miliary disease, you're not going to do cytoreduction, so they just close down. Then no meaning chasing what is felt, what is seen. But you know what I'm worried, Amita, is if you look carefully, where did they detect this extra 29 to 35%? Where would you normally expect? There are some hidden areas. Okay, Pontis hepatis, omental bursa, Winslow foramen. But you'll be surprised, 95% of the extra disease this dye showed are normal part of the cytoreduction. Where it is? Pelvis, right fallopian tube, left ovary, paracolic.
Right.
So which means all that is either a part of our normal cytoreduction. What did it change? Only thing that changes 15% paraiotic node.
Yeah, I agree
I
with
just
you.
want to make out one point here. The identification, what you have asked Amita here is, I think in this particular study, it looks like that if suppose we can identify 33% of the additional sites which we might have otherwise missed on the cytoreduction, is definitely, it's of benefit to the patients. And what is
not
important
microscopic,
is
as much as 1.2 centimeters.
Yeah, I think that point also I think we should discuss. The other thing is post NACT, you can say the likely chance of missing up the lesions was comparatively more. So I think so far as this thing is concerned, but I think if I look at the paper itself, and we look at from where did they all detect the disease, you see that they have seen in the pelvis. They mention about the, you can say, epiploicae, that is sigmoid epiploicae. They also mention about the omentum, the paracolic gutters. There is no mention of the disease in the upper abdomen. Of course, the retroperitoneal also they mention.
Right. So there are some concerns. So let me quickly move on to.
I think these are very controversial. These are the controversial points and the controversial aspects which I look at this disease so in this paper very much critically.
Absolutely. Satinder, quick comment, and Aditi.
So what I feel, it looks very promising, ma'am, especially in cases which are post-neoadjuvant chemotherapy. We are actually not sure whether they are necrotic, these are post-chemo changes, or there is disease in that. But the problem is, since there's 25% false positive rate, we really don't know the extra morbidity which we are going to give to the patient because of the extensive resections we'll be doing because of these false positive cases. As if we see their appendix, they have written there was a patient in which partial hepatectomy was there and bowel resections were increased. So the extra morbidity which we are going to give to the patient, is that going to add to the survival benefit or not, is not which we can make out from this paper as of now.
And if Aditi there, is she there?
Yeah, I'm here. So I agree with Dr. Rama and Satinder, and I would also like to add that, this is something that has been around for quite some time with the peritoneal surface oncologists. There are some old studies. One thing was that it's a very tedious procedure. They've not specified how much it added to the operative time and what were the areas they explored. What I understand, it takes a lot of time, and many a times interpretation is also problematic. So, and mixing early stage and advanced stage for me is not the right thing to do, because you are like, you are looking for lymph nodes, you are looking for extra disease in patients with stage 1 and stage 2, where there is essentially pelvic disease, and you are looking at additional disease in primary and interval cytoreduction in advanced ovarian cancer. So they are like just comparing, they've just put all the patients together.
Absolutely, I agree. And I was also wondering.
And one more line I want to say,
everywhere-
Aditi, in the supplementary material, they mentioned the time is 15 to 45 because we do it routinely. We have found that it adds not more than 50 to 40, but in the trial of that 106 patients, 15 minutes an average and never more than 45 minutes to screen everything. And at the end of cytoreduction, again they screen because this dye stays for a long time so that there is no positive. So it is not very tedious. ICG is very tedious. I agree. It took a lot of time,
I think
but here not.
Time is mentioned in the paper, but I agree with all of your comments that it's, just 100, and even if we take the entire cohort of 150 patients, 109 evaluable and very, very heterogeneous group. I don't know how FDA approved this drug so quickly. So I'm sure there must be some compelling reasons to approve it. Not drug, the molecule. Okay, so I think what came out of this discussion is, I think, two very valid, important points. One, survival advantage. Any new thing we are using, it either has to show survival advantage, and also it should not be detrimental per se. So both of these points, I think we are not very sure. Let's look at the survival benefit, because that's very important. And as Somashekhar very rightly mentioned, that most of the time disease was picked up at places where actually peritoneal surfaces. It was not somewhere very, very hidden. So the question is, and it's not related to this study, but in your routine practice, what do? Do you practice total versus selective parietal peritonectomy in advanced ovarian cancer? So let me start with Dr. Tongaonkar again.
Well, I think my philosophy is individualized. In patients who have primary cytoreductive surgery where the disease, peritoneal disease, is much better defined, I would probably do a selective parietal peritonectomy. But in interval cytoreductive surgery, where you can't really make out which is a diseased area and which is not, and especially if the patient has not had a preoperative pre-chemotherapy laparoscopy, then my philosophy is to do a total parietal peritonectomy. I think that's much safer to do that. And as Soma also mentioned, doesn't really add much to the operative time at all.
Okay, so Dr. Joshi, one quick...
lot is being said about 1.2 centimeter, 1.2 centimeter. Well, it's a horizontal spread. It could be on 5 centimeters. It's a microscopic spread. So 1.2 centimeters is no big deal.
Right. So what's your practice, Dr. Joshi? I mean, one quick total or selective, because I think in the interest of time we have to.
I think very rightly pointed out by Dr. Tongaonkar. In practice, when we are able to see that the disease is limited to the particular areas of the peritoneum, I go for the selective peritoneum.
No, so we are talking about
that means
whether you will do
peritoneum.
Total parietal peritonectomy, regardless whether peritoneum is looking normal or abnormal. So that's the question.
Peritoneum is looking normal. I don't go for the total peritonectomy.
Yeah,
I go for the selective.
Selective. I prefer doing selective peritonectomy.
Okay, and let's come to two other surgeons, Dr. Aditi and Dr. Somashekhar.
So we do total as part of a study protocol approved by the ethics committee. We have an ongoing study, and we tell the patients that this is not the standard of care. It will increase your cost and hospital stay.
Your routine practice is selective.
Routine practice, yes, would be selective outside the study protocol.
Okay, and so
let me ask Dr. Aditi. I think Dr. Aditi, your own paper says that total parietal peritonectomy, after that, the peritoneal recurrences are much less.
Yes, sir. But sir,
Then,
we have
then
not.
why don't you follow that in clinical practice if your
I
own
will come
publication?
to Aditi's paper. Let's just
No.
have a quick yes or no
Yeah.
from Somashekhar, and then
Yeah,
we
see,
can
in my institution, we always do total parietal peritoneectomy. I agree with Amita, it's not a standard of care because we published the first study ever in the total and parietal in ISSP journal, where we found that total parietal peritoneectomy in our group, it is not a randomized control, reduced the in-field peritoneal recurrences from 55% to 35%. And that's a paper we published 5 years back, and after the 3 more. It is not a randomized control trial, not a level 1 evidence, but in my institution, we always do routinely total parietal peritoneectomy, but it's very important for audience to know it is not standard of care.
Right. So I think medical oncologists in the audience can realize how much controversy we all have. Dr. Bafna, anytime if you want to make any comment, please feel free.
Sure. I'm listening all of you.
Okay, good. So we just heard that how controversial it is, the extent of parietal peritoneectomy in advanced ovarian cancer. And as very rightly pointed out, there is no level 1 evidence in favor of removing the entire parietal peritoneum. We can't remove entire visceral peritoneum anyways. So this is, I have actually selected few Indian studies. This is very recently presented in IGCS meeting by Calcutta group. And they looked at a fairly large number of patients, a randomized retrospective study. And what it showed that total peritoneectomy in advanced epithelial ovarian cancer is not associated with increased DFS or OS, but caveat is it's a retrospective study. This we just heard Somashekar's publication, where I got this one where you have included ovarian as well as other peritoneal surface malignancies, and your conclusions were what you said, that there is increased in time and cost and duration of
There is one more paper which is only ovarian we have published before this, exclusive
Right.
ovary.
So this is after that I thought I would take this, but yes, technically feasible.
That's exclusive ovary. Yeah,
Right.
we have one more.
And of course, this was the thing I think Dr. Tongaonkar was mentioning about Dr. Aditi's work in this field. So Aditi, would you want to make a quick?
No, I would just want to make a quick comment. Like we have to call it selective, but in most cases we end up doing a total, because when we thoroughly explore the abdomen, we always find scars, we always find some nodules. But since it's not the standard of care, we have to give the option to the patient. And if the patient agrees, most of the patients are convinced and end up undergoing a total parietal peritoneectomy. But I cannot recommend it outside a study protocol.
So I think all whatever literature we have suggests that histologically you will find more microscopic disease if you do total parietal peritoneectomy, but whether that translates into survival, we really do not know. And what is needed is a proper randomized trial comparing the two, which is, I think, we should, India
so we have
currently Vic Verwal has initiated a RCT in that. We are part of it. Through the Sweden, so there is a RCT.
So that's
but
good.
you know what, Amita, what is the criticism when we discuss this paper? Remember, only 20% of the peritoneum is parietal. 80% is on visceral, and we are conveniently ignoring. If we have a disease on a parietal peritoneum, just because we can't remove everything on the spleen, on the small bowel, jejunum, stomach, we conveniently say, so 80% of peritoneum will leave.
Right.
And 10%, that's why people comment like that. What is easy
criticism that it is actually may not be safe to do complete peritoneectomy in every patient without having disease. Removing entire mesenteric peritoneum and stripping everything is not really ethical unless we really have good evidence. So let's and if we just look at this thing what Dr. Tongaonkar also mentioned, that removing microscopic disease, does it really lead to survival benefit? Corollary of this is that famous Lions trial where retroperitoneal lymph nodes were removed in patients where nodes were clinically and radiologically negative. And what is very interesting to see that in this, more than 50% patients actually had disease in their lymph nodes, but it did not translate into either progression-free or overall survival. And we have to remember that conventionally lymph nodes are thought to be, chemo-resistant site. So even there, it did not really lead to any survival benefit. And it was, as expected, was associated with increased complications. And as a result of this trial, nowadays, most people actually do not do a complete lymphadenectomy if nodes are not enlarged. So I think same logic can be, of course, it is just extrapolation that removing microscopic disease may not really lead to survival benefit unless we have evidence to the contrary. And as a result, if you look at guidelines, this is NCCN 2023 guidelines, and what it says that all peritoneal surface should be visualized carefully. Any adhesion, any suspicious area should be selectively excised or biopsy. So guidelines currently do not mention to do a complete parietal peritonectomy. Of course, disease peritoneum we have to remove, whether it is parietal or visceral. So, I mean, why we are discussing all this? Because the study, although it showed 33% extra pickup, but most of these pickups were essentially peritoneal pickups, and we really don't know whether that extra pickup would actually translate into survival or not. So that's one point we really don't have evidence that doing this extra surgery will lead to better survival. So the other point I think is harm. Benefit we are not sure. The harm. So the question is false positives and false negatives. Let's focus at false positives. So 25% false positive at patient level and 32%. So let's take the lower figure, 25%. 1 in 4, you are going to get wrong results. And that's essentially because, folate is important. Folic acid is important in normal cells also, which are metabolically active. So it will, those cells also will pick up, and that's the reason to have false positive rate. And what is interesting to see, the common sites for false positive are lymph nodes, omentum, uterus, any inflammatory tissue, but as well as intestines and kidneys. So Somashekhar, what you said that if I see the entire bowel lighting up, now we are never sure whether that brightness is because of false positive or if there is disease. So that's a big concern for me, if it has such high false positive rates. So how do you all interpret this, and how do we in clinical practice take this point?
And also, Amita, Amita, there is something in the paper, now most of the good centers do very good cytoreduction, like all the people who are in this panel. Now it is proved by a landmark paper, like Petrolio et al. Paper showed in a very good gynae-onco unit who do CA ovary. After adequate CC0, what is reported, which are the commonest site where it fails and still patient failed to get OS benefit. Small bowel is 80%, hepatic hilum is 18%, truncus ciliacatus 10%. I expected that probably this study would try to throw light which are those patients, this disease is there. But if you look back, these 3 sites, which are the commonest site, it recurs in spite of the best CRS, actually, unfortunately, are not the site it is picking up. I am disappointed. All the things they have written is a part of normal surgery. And these 3 areas where my patient is going to fail in spite of the best surgery, with or without IPEC, is not an area. So somewhere something is not right. I felt very uncomfortable with this.
Yeah, and also my concern is removing these organs, unnecessary surgeries. That's something serious issue. So doing bowel resections or extensive lymph nodes may lead to additional morbidity. Dr. Tongaonkar, you were saying something, sorry.
I was just saying that the paper which he quoted, all those patients who relapsed did not have, it was not necessary for them to have a complete gross resection. Some of them did not have a complete cytoreduction. So probably there was some microscopic disease that was left. And that's why they have relapsed. If you take patients who have had a complete gross resection, I think this rate would come down. Intestine is not that common a site. Its intestinal surface is not that common a site of relapse.
Mesentery, yes, we do see, and they do present with the obstruction and all of that. So that's, I think, a big concern, that especially for when Dr. Parikh said how, can we apply it, unless someone has good experience and good understanding of this false positive, I think it may be detrimental, or it may be rather dangerous to start using this technique. Any comment on this? Otherwise,
Yeah, I think it's a very important point to be really taken into actual consideration, because false positivity and going for the extensive resections based on this actually, and we ultimately come to know this is false positive. So naturally, the morbidity of the procedure actually done based on the imaging, you can say, is going to, I think, is not a matter of, rather it's a matter of concern, and we should really be looking at it very critically before we start actually following this trial results into
right. And
this.
in fact, I was thinking if it can be used in early stage, where we are always, debate whether lymph nodes to be removed or not.
Absolutely.
But looking at that, lymph nodes are common sites. The most common site for false positive is lymph nodes. So they are also, it's not really going to help us.
I think to me, it looks like, if I can be allowed to make this comment, that after the surgical cyto reduction, if we can pick up the sites and the lesions, that will be the best to know whether we have done R0 or not. What we are labeling it as R0 may not be R0, because we are still actually are likely to pick up the lesions which may be having the disease.
Yeah, so that's what done in this study.
Early stage where the disease is limited to the pelvis. If we can know there is any kind of the small disease which may not be actually picked up just by the white light and palpation as inspection. So I think there it can have some value.
Rama,
can I have one?
Yeah.
Yeah, my question is to Dr. Somashekhar, that anywhere the authors have not mentioned that this is simply a hypothesis generating paper. So they are, sort of propagating it as a confirmatory trial. So what is your comment, Dr. Somashekhar?
We already got FDA approval. So this
No, this is definitely not a hypothesis, sir. There are
Because there is still, I could hear all of you, lot of confusion is still lying in it.
No. The only issue is overall survival and PFS is not there. What I mean to say is there is no doubt. It proves that you will pick up 35 to 36% more nodules, which a visible eye and palpation will not pick up. But this particular extra pickup, will it translate into OS or not, is not there. But there is no doubt that this dye cytolux is definitely beneficial. It helps more than 1/3 to pick up. But will that translate? We don't know.
Right.
See, like we always say in oncology, what can be done and what should be done is different. Just because something can be done doesn't mean that should be done. So because it can be done, we have a dye which shows us better. Does that translate into OS? We don't have. Which this shows OS benefit, if not OFS, even in field recurrence.
Absolutely. So we have, I think we are running out of time. Aditi, Amish, and Satinder all of have some question. Yeah, Aditi, Amish, maybe as.
Yeah, so extending to what Dr. Amita, you showed on NCCN 2023 paper or the guidelines, and what Dr. Somashekhar said, on one side, we are debating total parietal peritonectomy, is it helpful or not? On other side, we are using these technologies to identify few extra lesions where we don't know that removing en bloc peritoneum is helpful or not. And here we are still waiting for PFS and OS data. And if FDA approves, it means that tomorrow onwards, every surgeon should be, if the facility is available, should be using this. Is it really justified till we have the long-term results?
Absolutely. So I started my discussion with this point only, that somehow it got FDA approval even with this, even this paper came into publication. So the point is what Somashekhar said and what others said, total parietal peritonectomy is not the current standard of care. Guidelines say you remove diseased peritoneum or abnormal looking peritoneum. So, and what we are discussing here, that doing total parietal peritonectomy also does not add to survival. No study has shown that it improves survival. So removing something, this is something between total and selective, something in between. So that is unlikely to benefit survival. So that's one point, Dr. Bafna, that there is what Somashekhar very clearly said, that there is no survival benefit from this use of this technology. And the other concern, of course, is these false positive rates leading to unnecessary surgeries and unnecessary complications. When we, these were very selected patients done by selected people. But there is always risk of if everyone starts doing unnecessary bowel resections or lymphadenectomy, there is increased risk of complications. Aditi and Satyendra, yeah.
I wanted to say that, they have not got any data on false negatives. What if it is negative? Like there are certain regions, we've done a lot of studies on that where we've taken random biopsies from the peritoneum and showed that certain sites, especially after NACT, are more prone to having occult disease. So if I were to compare this to a TPP, if my TPP study shows that there is a survival benefit and somebody might say you can use fluorescence and, limit your resection, then I would want to see their false negatives. That lesser momentum in our practice is positive, occult disease is 50%. So we end up removing the lesser momentum in all patients without much morbidity. But if this study actually it has to change practice, then they have to take random biopsies from areas prone to harbor occult disease and prove that when this fluorescence says it's negative, it is true negative. That is
so that is one caveat, that false negatives were not really studied.
Yeah.
And
No, about the sensitivity, they have said is about 86%.
Yeah.
So about 14% false negative is there.
Right. So that also actually how they have calculated, I didn't understand whether that was for folate receptor.
I agree. I also tried to read a lot, but the way it is devised, I think they never looked at false negative in this. They never have looked at positive nodules by visual, and which fluorescence has not happened probably.
So what they say, it is adjunct. You always do this thing and add it to. So that is the thing. Yeah, Satyendra.
So I wanted to add, ma'am, this study may be useful in selecting more patients for neoadjuvant chemotherapy. Along with diagnostic lab, if we use this dye.
I will come to that, how we can do even without diagnostic lab, Dr. Joshi.
Yeah, I think so far as my another question is that whether we are going to actually select the patients who are having the folate receptor positive. Because maybe the 8 to 10% of the cases,
So
are we going to subject all the patients and giving them the dye and then going ahead with that of the study? Should we extrapolate it to that level?
Right. So that some of the points, I think if we want to bring it to clinical practice, of course, one concern is toxicity, especially immediate prior to surgery. If patient starts vomiting, it's really going to be a very challenging thing. Cost, Somashekhar did mention, but the next point is, should we be doing folate receptor on all patients before we can do this, and I actually asked Dr. Parikh, I don't know, he promised he will get back to me, but I actually was trying to get folate receptor study for one of our patients. I'm not sure if it is being done in India in a standardized way. So these are some of the challenges we need to be careful. But anyway, despite having many limitations, we know that fluorescence guided cancer surgeries is something is in a big way. It's just not for detection of tumor, but also margins, also lymph nodes, also vascularity. And if you see the number of publications in recent past, it's just a reflection of how fluorescence has come in a big way in cancer surgical field. And this is the thing, Satyendra, you said pre-operative. So instead of laparoscopy, in fact, you have folate receptor targeted PET. So I think that can substitute a laparoscopic procedure. Again, I'm not sure if it's available in the country or so, but it is something.
No, Dr. Kalluri is doing some phase 2 study on this, but not very concrete. He was writing a protocol and on this, because he started with FAPI first, then he changed to folate. But it's
right. The other indication where it is FDA approved is lung cancer, and I think there it makes more sense because lung is slightly different than ovary. There you don't have thousands of nodules. You may pick up extra 1 or 2, and that may be useful. In fact, there are studies on lung cancer also where this Pafolacianine has been used extensively and has shown to pick up extra few nodules. The other, and I think the more important point for me, is folate receptor alpha directed antibody drug conjugate therapy. So, Dr. Bafna, I think this must have inspired you to select this paper for us. And so, what's your your take on mirvetuximab?
So for all the oncologists, the platinum resistant ovarian cancer is a very difficult clinical scenario to treat, and we have been striving to get the correct molecule for this group of patients, and eventually all patients will develop platinum resistance. So in these patients, there are at least 4 antibody drug conjugates have been tried. And one mirvetuximab, which we are showing on the screen, is now FDA approved. And this has been, so and this was the Soraya study. And this has been shown to be very promising and effective even in the 4th line, where the overall survival benefit has been shown in comparison to the conventional chemotherapy, which we have been using. So the overall primary endpoint of progression-free survival, overall response rate, and the overall survival in all the 3 trial endpoint, there was a benefit by using this antibody drug conjugate. And regarding the question of you asking about the test of doing the folate receptor alpha, so this is need to be done by the Ventana by Roche, using the RxDX assay.
Right.
So other companion diagnostic test will be of very little value.
That only. But is it available in India? Is
soon it will be available.
Diagnostic doing in India, or they send it to their
Roche, if there is any patient, I have inquired that they might help in doing this test and also getting the this mirvetuximab drug. And the Mirasol trial is very encouraging, and all the medical oncologists are quite excited.
Sir, what is the cost of this drug, sir?
I'm sorry, I really don't know. But in 4th line, if you are showing the
your patients will be able to afford, don't worry.
So even in 4th line, if you are showing the benefit in overall survival, especially in the patients who were treated previously by bevacizumab and PARP inhibitor, I think the future is very bright for platinum-resistant ovarian cancer patients.
In fact,
one question to Dr. Bafna, can I?
Yeah, sure, Rama. Hi, how are you?
Yeah, nice to see you. So actually, don't you think that there's, after this kind of a molecule being used in the platinum resistant, and after 2 to 3 lines of chemotherapy, would you like to use it earlier than that of 2 to 3 lines of chemotherapy?
Yeah, this is a very interesting question. So they have dissected the result of Mirasol in the patients who were not exposed to bevacizumab. The hazard ratio for progression-free survival was much, much better than the patients who received the bevacizumab. So sooner the better.
Yeah, even PARP inhibitors, patients.
Yes,
yes. Amita, can I request you 5 more minutes?
Yeah. This is last actually. So we have 2 very important trials. Soraya trial, which was presented in ASCO last year and subsequently published in JCO and led to approval of this drug in platinum-resistant ovarian cancer, FDA approval. And the other one is Mirasol, what Dr. Bafna just mentioned, which was presented in ASCO this year. And this is a randomized phase 3. That was a single arm study, Soraya trial. And what it showed is you can very clearly see that there is definite statistically significant improvement in progression-free survival, as well as objective response rates, and as well as improvement in overall survival, right? So that's what. And drug cost, Dr. Bafna, somehow he doesn't want to disclose.
No, what is surprising, Amita, in this is in that line, 3rd, 4th line platinum, 15% pathological CR and 0 in the other arm. Unbelievable. 15% PCR, somebody would kill it for it, in that line.
So soon we will be out of business. The patient diagnosed, do receptor studies and drugs.
Yeah, but who will, yeah, I agree.
Yeah.
But, I will tell you, Amita, what I look at it is, since there is, unless the follow-up studies based on, this particular study. I'm not speaking about this, I'm speaking of Cytolux, the Pafolacianine. So if they don't show OS or PFS benefit in subsequent trials, people follow up. This is the first trial, so people had to, proof of concept is proved, benefit is fine, but we need to see. If they don't show that, at least they must show infield peritoneal recurrence is less. If they don't change, then most important, like the fluorescence study in colorectal and other, where there is a CEA tag fluorescence and bevacizumab tag, where change in decision making, you start with curative, because of this you change the decision to palliative, or you started off with this defined cytoreduction, then you change of decision has to be proved, or infield peritoneal recurrence has to be proved, or OS PFS, which is very tough. If these are not addressed and the false positive rate is not brought down significantally, it's becomes a little bit academic trial.
Absolutely. There
For
are
this
many,
particular
many new molecules which people are studying, but of course, all of them are waiting FDA approval. What is interesting here with this drug, early separation of curves which persist. So I think with this, we will end the discussion here. So my take is that targeted imaging, what we have learned from this study for ovarian cancer, is feasible and it is safe. But there is no data on long-term clinical benefit, including recurrence-free survival, overall survival with this imaging. We really don't know. There is definite room for improvement, what Dr. Som just mentioned, that we need to make this technology better and have more results in terms of clinical outcomes, especially survival, and bring down false positive rates. And folate receptors, alpha-directed antibody drug conjugates, I think they hold very bright future in folate receptor positive. In fact, a number of other drug conjugates have been tried and they are under investigation. So in future, I think we will see more and more of these this thing. And with this, I think I will end.
And one other thing is alpha beta is not explored. If there is a dye which can target both alpha and beta, then 99.9% fluorescence will pick up.
Right.
So that's
the
also
other
a
thing is, so it's just not pick up positive or negative. There is a gradient. And what is important for them to be clinically useful, to have a 3+ kind of strong staining, which is actually not in 95, that is only in 36 to 40% patients have strong staining. Some staining you may find in more than 90%, but the meaningful staining is not in all of them. Right.
Amita.
So with this, I think I will end the discussion. Yes, sir. Sorry, you want to make any comment?
One comment, one last, is whether we identify 90% or 99% of the lesions, unless we have a survival benefit, all this is not going to be of any use. There are multiple There are multiple instances of clinical trials where we look at surrogate endpoints, and a lot of drugs are, approved on basis of that. Getting a peritoneal recurrences reduction in that, in my opinion, that's not a great endpoint at all. Because that doesn't really help me to reduce the mortality, reduce the, or improve the survival.
Right. So OS is the hardest endpoint to prove.
Very tough, but one of the surrogate, see, the whole thing about surgery, intraperitoneal chemo, HIPEC case, it cannot prevent disease extra-abdominal. It's only loco-regional control. And loco-regional control with the systemic can have. See, systemic control without loco-regional control cannot translate to cure. So the way it would do is that, but we don't know. We don't know that extra fine microscopic control will it translate to OS. I agree with you, sir.
Unlikely that it will translate. I'm a little
skeptical. One thing we miss is preservation of quality of life. If we have less ascites and less obstruction, then that is a meaningful thing. But we have absolutely no data on that in ovarian cancer.
Absolutely. So what we need a properly conducted randomized trial. So I think that's need of our, and so mentioned that there are already ongoing trials. So I just last point, I think more than ovarian cancer, it may be useful for something like lung cancer surgery, where you just pick up 1 or 2 additional lesions which are not seen on imaging. So that's my take, and it's approved for lung cancer. That's the second approval which happened last year. So I think with this,
Dr. Amita.
Yeah. So
so just since you mentioned about the lung cancer, and since Dr. Amita, since you mentioned about lung cancer, just the addition of immunotherapy to chemotherapy in neoadjuvant setting increases the PAT-CR and resectability from 15% to 40%. So I think that can be also one of the ways of improving the outcomes, where we have the not surrogate markers, but we have a proper confirmed primary endpoints of PFS and OS, which we can look at, as Dr. Tongaonkar sir also said. With that,
So what
Dr.
I was
Amita,
trying
can I
to say that if you are doing surgery for lung cancer, and if you are seeing only one lesion on your pre-operative imaging or intraoperative assessment, if this can, there is a study which showed additional maybe 30-40% second lesion was picked up in lung, which was not seen or felt otherwise. So there it may be useful that you can, same sitting, you can remove additional lesions, of course. I mean, that's
is it also FDA approved without OS?
Yes, it is FDA approved.
Okay.
So first approval ovarian, followed by lung last year. Yes.
Okay.
Thank you very much, Dr. Amita and the esteemed panelists. I think we have really discussed threadbare what the finer points are. Now it is my honor and privilege to introduce to you Dr. Harit Chaturvedi. Now everybody knows that he is the surgical oncologist in the NCR region and of course all over India and the neighboring. But I think I should, appreciate his dedication in some other field also. If you look at the success of the third ICC in Geo Convention Center, the foundation of ICC was laid by Harit Chaturvedi. And therefore, I think his initiation has led to oncology being at the international platform in a very nice manner. And in a similar way, for this article also, his expert concluding remarks will be extremely valuable. So without wasting much time, I hand over to Dr. Harit Chaturvedi.
Thank you, Dr. Purvish, for such a generous description and kind words. Thank you. I think we have had a fantastic panel, and there could not have been a better panel than this, and a really threadbare debate on every aspect related to this topic. And it has really added a lot of value in the sense of understanding of the whole pathology, where we are going, what are the challenges, why we are failing, and new molecules are required, but really nothing is changing the game on ground. All this is helping us see new direction. All this is helping us find a new way of treating. But still, there is a long way to go before we change the needle in terms of survival, in terms of overall outcomes. And that is what the challenge is. But I think for us on this panel, since it is written by so many leaders in this space across the country, time has come that we should initiate some dialogue, some conversation, some trial, some data from our own setting using these new molecules and seeing what we can add value, what can add value, or what can happen. But if you ask me, will something change in my practice? So I don't see really anything changing in my practice. I do what is called a total peritonectomy in patients where there's upfront disease and selective often, but whenever there's no disease on the peritoneum, when we do interval site reduction, I'm actually quite confused. There is no point in stripping too far and going through the morbidity of all that. So there are challenges. There are a lot of issues unsolved, unresolved, but nothing changes on ground as far as practice is concerned. The hope of using these targets in terms of systemic treatment, in terms of identifying disease, in terms of tagging new molecules is definitely a big takeaway, which should guide us to explore further in terms of treatment. So that's all I can say. And I think the panel has truly dissected the chapter or the topic very well. In fact, I stepped out in between for something, then I came back hurriedly because I realized that it's a really high-powered topic. I should listen to this panel for a real insight into this. So it was quite insightful. Thank you. Does that
Thank
answer
you very much, Professor. Go ahead.
Does that answer your questions about? I don't
Very
think my
much.
practice is going to change from this.
Right. So that is important. And I thank you very much for your
opinion from others also. For me also, it doesn't change anything, even if it's available. They have ICG system.
Yeah.
Thank you very much, guys. All of you have done a fantastic job. And it is my duty to remind you that the next Oncology Beyond the Obvious will be held as usual in December on the second Tuesday, which is second Tuesday of every month. So it is on 12th December at 7 p.m. And we hope to see you there at that time. Thank you very much. Good night and have a wonderful rest of the day.
Yeah, thank you very much, Dr. Parikh and Dr. Vora, for the opportunity. And thank you all panelists. Thank you very much for a wonderful discussion.
Good night.
And thank you, Dr. Chaturvedi, for summarizing it so nicely. Good night.
Good night.
Night.